I am going to present on tattoo using tattoo gun, which was also innovated by Aditya actually. So coming to some pre-operative checks, which includes the visual acuity, intraocular pressure measurements, anterior segment photograph for the exact overall cosmetic appearance after surgery, the limbal health, presence of clock hours of vascularization. ASOCT is very important to demarcate the area of thinning, as Dr. Aditi has already mentioned, and we will see in the subsequent video. The posterior segment status, the consent for the procedure is of utmost importance. Then chances of fading needs to be explained to the patient once and again, because it does happen, and one needs to repeat the procedure post-op again in the post-op period. So these are the overall components of the tattoo gun: the adapter, cable, switch, the handles, multiple needles, speed can be adjusted, as well as the depth. The technique, it's a useful technique for basically anterior stromal scars. Their automated micro punches are performed involving the superficial layers of the stroma up to a depth of 2.5 millimeters from the corneal surface. And the penetration depth of the needle is controlled by the length of the longitudinal axial vibration of the tip. And there are different tips and needles available depending on the area that is going to be treated. Speed can be kept in a medium range, and a micro drop of stain is sufficient enough over the corneal surface, followed by micro punctures which are performed down to the superficial layers of the cornea depending on the depth of the scar. And the procedure is repeated after multiple washes until adequate amount of pigment is introduced into the superficial cornea to achieve a acceptable cosmetic appearance. Some of the intraoperative measures are selection of the depth of penetration of the needle depending on the depth of scar, areas of thinning to be demarcated to avoid perforation intraoperatively. Automated micropunctures are performed during the procedure. Less than a drop of dye is sufficient enough to cover the entire surface for one round, as the excess dye would get washed off. Application of bandage contact lens at the end of procedure, which would stay there till the surface epithelializes, be it a month or a month and a half. And need for tarsorrhaphy in cases of poorly fitting BCLs in irregular corneal contour should be explained to the patient. So my experience in two case scenarios, one for cosmesis and other for cosmesis plus visual rehabilitation. This is a short video which I'll be. The indication is basically a leukomatous scar with BSK, where BSK removal done with diamond buckle knife followed by diamond burr polishing, cauterization of the blood vessels being performed. Followed by placing a drop of ink over the surface which was spread, and then the tattoo gun was used to make micro punctures in the cornea intrastomally, and covering the entire surface of the cornea till the limbus in the similar manner. The procedure is repeated multiple times after several washes being given till one is satisfied that the entire surface has a cosmetic acceptable outcome. The excess dye is removed after washes and with sponge. The complete surface is covered, and then at the end of procedure, after washing, a bandage contact lens is placed. So this is at the end of surgery. BCL was applied, and this is the post-op day 1 appearance. So the post-op medications would include antibiotics, steroids, and lubricants post-operatively. Drawbacks of this procedure can be in the form of discomfort and pain because of the epithelial involvement, and can result in PED till the epithelium heals in cases where the limbus is not healthy and the vascularization of the surface of the cornea is there, which impedes healing. And BCL stays till the epithelium heals. To conclude, tattoo gun helps us achieve. No, one video actually got skipped. I will just play. This is the second indication where it's used in case of a large failed graft, status post therapeutic penetrating keratoplasty, marking done with 7 and 8 mm trifines, and the dop of dye placed outside 8 mm to cover the rim which would be there as a white area outside the graft actually at a depth of 1 mm. So again in the similar manner, multiple intrastromal punctures are made outside the 8 mm marking that was done. This is repeated 3 to 4 times after multiple washes till a cosmetic acceptable dye we can see at the end. One has to be careful that the central area doesn't get covered with the dye because intraocular penetration has to be avoided in any case because of the side effects of the dye. Flaringa ring is placed and a 7 mm trephination done, followed by a optical penetrating keratoplasty and then sutured with 16 10 nylon sutures. This is the post-op 1 day appearance, and it's 5 months with a BCV of 6.9. This is a last video where we can see actually an area of thinning was there preoperatively which was not very well delineated on ASOCT examination, and intraoperatively area of perforation was encountered which we'll see after this wash. A gush of aqueous was seen. So this is just to state that one has to be very careful and examination with ASOCT, the area should be demarcated before performing this procedure to avoid such complications. So to conclude, tattoo gun helps us achieve a better, consistent and uniform keratopigmentation results.